We're going to be continuing actually the discussion of testes. Alright, gonna be a short and sweet lecture hopefully. Starting with some non-neoplastic conditions of the testes, including acute epididymitis and orchitis. As I mentioned to you, usually age is a very important factor when it comes to the pathogen. So depending on the priority in life, those who are less than 35, it has to be something like that's related to STDs, chlamydia, or gonococcus. In a male above 35, usually it's going to be due to E. coli or Pseudomonas. That's when the GI tract actually will take over, if you ask me. And how does it present? It presents with a sudden pain that happens in the scrotum. Now, with sudden pain, that's going to go into the differential diagnosis with a very important, entity, which is torsion testis, right? And there's a long list of tests that you have to do, including some imaging and imaging studies that you have to do in order to figure out exactly what you are dealing with. Both of them are going to be associated with enlargement, probably this one as a result of the inflammation. The other one is going to be associated with enlargement as a result of the block in the circulation, first venous and then arterial eventually. Both of them are going to be actually presenting most commonly 99% of the time unilaterally. What you're going to be finding actually with the inflammation is that if you try to lift the scrotum with your hand, the pain is going to be lessened when it's inflammation. That's not going to be the case when it is torsion testis. All right, so something to keep in mind. Of course, clinical is from the clinical guides, but we can add a couple of words about this. Tuberous orchitis, that's going to be starting from the epididymis and spreading to the testes. Syphilis is the other way around. A couple of words about this. Now, mumps orchitis, this is actually courtesy of the folklore. Do you know what we call mumps orchitis in old Arabic folklore, words? تحذير. Anybody familiar with this word? محذر أو تحذر. Okay. So, and what is the risk of the mumps orchitis? What is something that everybody is going to be worried about? It's not going to be the parotid. It's not going to be the parotid that's going to be actually maybe associated with this, right? It's not going to be the pancreas that could be associated with this as well. So usually it's presenting, with a couple of inflammation in other sites, including the parotid and the pancreas, that the mumps may affect as well. But the actual fear is that it will result in destruction of the testis itself and in infertility. Now that's actually a very remote possibility. The reason for this is that in the majority of cases it's going to be unilateral. And in the majority of cases it's going to be only affecting the interstitium rather than the seminiferous tubule. So spermatogenesis will not be affected in that case. There's also, as you know, autoimmune disorders usually are disorders of females, right? But in this case, it is actually happening in a male. Autoimmune orchitis has to happen in a male. What you're going to be finding is that it will happen. Your patient is a middle-aged man who's presenting with inflammation in one of the testes. Usually, after a lot of considerations, a lot of investigations, you will not be able to find any cause of this inflammation. So it's a diagnosis of exclusion. The reason for this is that it is a pretty rare entity, actually. You will do serology on this patient, and you will see that the IgG is going to be through, the roof is going to be very high. Sometimes you may see actually one of the indication that this is, autoimmune orchitis is that it will be associated with another autoimmune disease. As you know, autoimmune diseases happen in cluster. So the same patient who has Hashimoto's will be presenting to you with type 1 diabetes will be presenting to you with vitiligo and so on and so forth. So that may be also the case. If you take a section, if it happens that you take a section, for of this, testis, you're going to be seeing actually non-castiating granuloma, which is what you see in this type of inflammation. Here is an example of a medical emergency, a very important entity that everybody should know about, the torsion testis. The name itself is a misnomer because in reality it is not really the testis that has turned on itself, that has twisted on itself. It is the spermatic cord actually that did this. And the first circulation that is going to be stopping in this case is going to be the venous circulation. Eventually that's going to be followed at the end with the arterial circulation. This is a medical emergency because if you don't actually interfere and untwist this spermatic cord, this testis is will die actually eventually. So it has to be done as soon as possible. There's some you will see you will read some places say 6 hours, others say 1 hour. You do it ASAP the minute that you have a suspicion actually of this, you have to interfere immediately. All of those actually swelling that are happening in this case are happening on an acute basis. So keep that in mind. This is acute, sudden entities that are happening on an acute basis, whether torsion testis, which is going to be the most acute, or inflammation. Now there are other entities that are going to be associated with what you call it a mass-like structure. Those entities are going to be dealt separately. This is when we get to tumors. So acute and painful and everything else is what we are dealing with now. So how does it happen? How does torsion testis happen? Sometimes there are actually no events that resulted in this. Sometimes it happened during sleep. Trauma may also cause it. There are some instances where trauma may cause this presentation. There is also the bell flapper anomaly, where you see that the tunica albuginum, that should really put the testis in place in the scrotum is not complete, and that's going to allow for a free movement of the testis and the spermatic cord and allow it to twist on itself. So how would you interfere? This is you have the patient has to be in the hospital ASAP, and in the OR, and this has to be untwisted. The testis that has been exposed to this has to be untwisted, and it has to be put back into the scrotum and fixed in the scrotum to make sure that it does not happen again. All right, hydrocele, on the other hand, this is also going to be actually a swelling, a mass, right? In this case, it will happen more chronic actually than the other entities that we have talked about. Hydrocele, where you start to see that actually between the two layers of the tunica vaginalis, you're going to be seeing accumulation of fluid, of transparent fluid. How would you be able to figure this one out? First, when it comes to
Translumination.
Sorry?
Translumination. Putting a light.
Right, exactly. Very good. So one way to do it actually to figure out if you have a hydrocele versus a solid mass is to put it against a light. So you would put a light beneath actually this scrotum. If it trans-illuminate and it went through it, that means it is actually more fluid. Of course, there are what you call those hybrid kind of masses where you see partially fluid, partially solid. You cannot rule out with a light test. You have to go in and you have to take care of business. Now what causes the hydrocele? And when it comes to acquired hydrocele, inflammation should be high on the list. That may result in this kind of presentation. Trauma may also cause it. The end result is going to be that these quote unquote mesothelial cells are going to start to produce this fluid that is going to accumulate between the two layers of the tunica vaginalis, similar to what you see, for example, in other entities. Where else do you see this happening? So these two layers, parietal, which is on top of the organ, and the second one, pleura, right, peritoneum, everywhere else, in that. All right, so that's actually the acquired. Now there is also congenital hydrocele. So what happens here is that, as you know, the testes are located during embryologic life in an upper posterior location, and then they will migrate, right, through two stages, transabdominal stage and transinguinal stage, into the scrotum. As they actually migrate, so they have a retroperitoneal location during embryologic life. As they migrate actually through these two phases, imagine this: they are going to be taking with them a part of this peritoneal covering. Those are actually the peritoneal covering that they used to be covered with during embryologic life will become actually the tunica vaginalis eventually. So what happened actually once they go through the inguinal canal and they are situated in the scrotum, this relationship with the peritoneal cavity is going to be obliterated. If it does not, if it does not become obliterated and there is still a small, like what you call it, communication, a very tight communication between the peritoneal cavity and the tunica vaginalis, that is going to allow the fluid from the peritoneal cavity to end up actually in the two layers of the testes, right? So that's what you call actually patent processes vaginalis. That's actually the cause of this congenital hydrocele. And if it's it's a hydrocele if this communication is tight, allowing only fluid. What will happen if this communication is larger, than that? Then not just fluid will come in, but maybe loop of an intestine may actually go through it. And then what would you call that? Hernia, right? That's going to be an indirect hernia. It's going to go through the inguinal canal and be situated, and that's going to open the door, of course, for an infarction of this hernia because of the tight location. All right, what else would you see in the scrotum? Including a hematocele, usually resulting from a trauma or a coagulation disorder. Spermatocele, in this case, in patients who have undergone vasectomy, once they, cut it, there may be accumulation of that in that region. Now, varicocele is an important actually entity. It's important because when it happens, it may actually result, in infertility. Because the temperature, for spermatogenesis, is towards the cooling part. Once the temperature rises, for whatever reason, for example, there are occupations that may result actually in raised temperature in that part of the body. Can you give me an example?
Glass meltdocks.
Well, there you go. You're from Syria, right?
Yeah.
I knew it. Yeah, because Syria is known for glass, glass making, glass industry at one point in time. Absolutely. So because the worker is actually sitting or is working in front of an oven, and all this fire actually, all this heat is coming to him. Is there anything else? Also, you have not seen it, I guess.
Baker.
Who said baker? Right. But do you see it here, baker? The old-fashioned baker, because so absolutely, baking, the old-fashioned bakers, used to stand in front of, a pit of fire, right? And that same exact thing is going to happen. Absolutely. So once that happened, once you raise the temperature as a result of the increased circulation, because now you have what you call tortuosity of the venous channels, meaning you have, a longer, venous channel through which the blood is going to be actually cruising around the, testes, and the end result is going to be actually raising the temperature of the testes and making it unlikely to be, fertile. Now, another application for this is that it is most commonly going to happen on the left side. Where does the spermatic veins, the testicular, where does the testicular veins drain into?
Vertebral.
Left side.
Renal
Vein.
Renal vein on the left side, and right side,
IV.
there's the inferior vena cava. So this one actually is here, showing you that it's going to be more likely to happen on the left side. Why is that the case? So without anything, we did not say that there is anything abnormal happening here. Go
It's
ahead.
because of the anatomy of the testes. The left testes is a little bit lower than the right one. That's where all the fluid can accumulate, and it's more prone to infection.
Well, like, have you studied somewhere else, or is it a guess?
I guess.
I guess.
He's
All right, maybe this is part of it. But here's one thing actually I want to tell you about. So the right vein is draining into the inferior vena cava, draining into a much larger vessel, right? A much larger vessel. How about actually when it drains into a much smaller vessel? then actually if you think about it, this is, physics. I'm not good in physics, but I can tell you that this is a column of water, right? If you think about the vein as a column of water, on the left versus on the right, the one on the right is going to have less pressure in it because it's going into a larger actually vessel. But the one on the left is going into a much narrower vessel. And as a result of that, at least this is how I reasoned it for me. If you find any other explanation, please bring it here. We can talk about it. So because of that fact, because of the fact that it's going into much narrower vessel, and will have definitely harder time to get into, it's that may be one reason. Another reason actually is that when it happens suddenly, if it happens suddenly, especially on the left, you have to actually consider, and this is really where my thinking came from. You have to consider that there is a possibility of a renal cell carcinoma developing in the left side, okay, developing in the left kidney, and that's the same exact reason, because when there is a tumor that is arising in the left kidney, okay, that is going to add actually more pressure to the flow out in and out of the kidney as a result of the fact that you have now a mass there. Even in the absence of any kind of a venous clot, a renal vein clot. Okay, if there is a renal vein clot, which is known to happen actually from kidney tumors, that may be even worse because that's going to even add more resistance actually to the flow of blood from the left testicular vein and into the left renal vein. If that makes any sense, go ahead.
So does an aneurysm also cause the same effect?
Aneurysm in what?
In, let's say, the aorta, abdominal aorta, so there will be compression of the left renal vein?
I think it is more related to the venous because it is the entity itself, the pathology, is related to venous, what I call it malformation, this tortuosity of the channels of the venous channels, not the arterial. So I think it's unrelated to that, if you ask me. But what I wanted to say is that it does make sense, doesn't it? Think about it as a column of water, right? On the right versus on the left, and on the right is going to be much, let's say in the case of a left kidney tumor, it's going to be much easier actually to flow on the right and much more harder to flow on the left, and that is going to be also compounded if you have a thrombus, an embolus, not the thrombus, an embolus that have escaped the tumor, a tumor embolus really, and now is in the left renal vein, and that's going to add more resistance to the flow of blood upward. Okay. Now, how does it feel if there was a picture, I took it out. I don't think it is appropriate to describe the pictures in a lecture for some reason. It feels like a bag of worms. Actually, it does look like a bag of worms, and it does feel like a bag of worms. So, all right. So now let's talk about testicular tumor. This is what you call the real deal, right? Now coming to testicular neoplasm, one of the few times that you see that the white race is a risk factor. Usually the white race is always a protective factor. Don't ask me why, but it is the case. I'm not being racist. I'm just reporting to you a fact. Cryptorchidism, on the other hand, associated with a 3 to 5 fold increase in the risk of cancer in the undescended testis. What's cryptorchidism? So the failure of the testes to descend, right? Is there any time limit to this? Within what? Within a year, probably?
2 years.
Within a year, within 2 years, if I recall, I think the number is about 2 years. Some people say it has to be within 1 year, and you will see that we will try to discuss it in a second. There are a lot of actually theories about when you should put the testis down in the scrotum. I will tell you that it does not matter for one reason, as we will see in a second. Another actually risk factor for the development of testicular neoplasm is intersex syndromes, including the androgen insensitivity syndromes and gonadal dysgenesis. Family history: if someone has a brother, who has actually germ cell tumor, there is higher chance. There's about 8 to 10 folds of development of germ cell tumor in the other brother over the general population. Testicular neoplasia in one testis is going to increase the chances, believe it or not, unfortunately, of neoplastic transformation in the contralateral testis. And now, the what you call it, the real deal here. The most testicular tumor arise from something known as IGCN, intratubular germ cell neoplasia. The way that I want you to think about it is that this IGCN is a carcinoma in situ. Okay? Carcinoma in situ, ground zero, from which all different types of germ cell tumors may arise. All right. And where do you see the IGCN? Let's say that there is a patient is presenting with a testicular neoplasm. If you cut that neoplasm, if you cut that testis harboring the neoplasm, you will see IGCN in about 85% of the time in the rest of the testes. So you will be able to see ground zero in the rest of the testes. And if you sample the contralateral testis, and this is something that you need to do during surgery only, you will see that there is about 5% chance that the contralateral testis will harbor IGCN. What do you do at this stage? Once you have IGCN, that's actually what you call it a death sentence, because you have to take. So this patient came in for one testis, right, because it was affected with one tumor, and now you have sampled actually the contralateral testis, and you found out that it is also affected with IGCN. What do you do to the other testis? You have to take it out as well.
Freeze gametocytes.
Sorry?
Freeze gametocytes, just in case.
Freeze. Well, like this is what a good doctor would think. To make him able to have, exactly. If you can do that, I don't know. Can you do this?
Yeah.
From
Before the surgery, not in the surgery.
Right. But from the testis itself, or from like from the taken out testis, the resected testis.
Sperm from the testis themselves.
From the resected testis, or while it's still like functioning.
While it's still functioning.
Okay.
It's called
They will learn,
sperm
right?
scraping.
Sorry, what's it called?
Sperm scraping.
Sperm scraping. Scraping.
They
Okay.
literally pick the sperm from them.
Right. And where did you guys get that?
We didn't. I saw
Movies.
it. No, I saw it.
I don't want to say what kind of movies, but
No, I saw it. It's a treatment for infertility.
yeah, because we have actually a faculty who is really into this a lot. I'm not sure if you guys recall him, Dr. Junaid.
Yes.
Junaid is like one of the premier people in the kingdom in this kind of research. Okay, so let's talk about cryptorchidism. So percentage-wise, about 1% of 1-year-olds have not actually descended their testes, at the end of the first year of birth. And that's what we call complete or incomplete failure. What is meant by complete or incomplete failure? As I mentioned to you, the testes will go through two stages: the transabdominal stage, okay, and the the transinguinal stage for it to reach the scrotum. If it does not move at all, that's what you're going to be calling actually complete failure, right? It is still somewhere in the abdominal cavity, so it did not really move anywhere. So that's something that's going to be a headache for you as a treating physician, because you have to figure out where it is. And the reason why you need to figure out where it is, because there is unfortunately a good chance that it may develop germ cell tumor. Okay? And why is that the case? Why does it have a good chance of developing a germ cell tumor? The reason for this is that it harbors the IGCN. This is really the reason why. So now they tell you that you need to put the testis in the scrotum by the first year of life. Others they will tell you have to bring it by the second year of life. You will see other studies telling you that you need to put it in the scrotum by the 10th year of life. It does not matter really when you put it in the testis, because at the end of the day it's going to be affected by two serious complications. One of them is going to be infertility. Most of the time those testes are going to be infertile testes. Why? Because the seminiferous tubule has transformed into IGCN, and IGCN does not produce, does not have spermatogenesis. That's number one. And number two, there is a good chance that it may go on to develop germ cell tumor. And that's also a very important thing. Why? Because this testis is buried somewhere. If there is complete failure of descent, it's buried somewhere in the abdominal cavity, and you need to figure out actually where this tumor is developing. All right, so we did talk about the two phases. Which is the most likely actually location for the undescended testis to be located? So the transabdominal, failure is going to be around 5%. The transinguinal failure, the inguinoscrotal, phase, if you will, is going to be the most likely, failure to happen. So most likely you're going to be seeing actually the crypt orchid testis located in the inguinal canal. Now, when it is located in the inguinal canal, that's a pretty superficial location, right, compared to the scrotum. So there's a chance that it will be exposed to trauma, right? This is one. Two, it's a pretty tight place, so there's a chance that it may actually be exposed to ischemia as well. So a couple of things that happen, of course, and the two, most important thing you would worry about are neither trauma nor ischemia, but are going to be infertility and germ cell tumor development. Now, the precise cause of the crypt organism is still poorly understood. They did a lot of hormonal studies trying to figure out actually if this is related to hormonal imbalances, and that did not really pan out. They thought that it is due to actually, the fact that the testis is not receiving enough blood supply. But then, unfortunately, they found out that the contralateral testis in patients who have a crypt orchid testis, so the contralateral, what we call good testis, that descended normally in those patients who have, a crypt orchid testis, is going or have a higher chance than normal of being infertile and also of developing, germ cell neoplasia. So obviously, it is not related to ischemia. It is not related to hormonal imbalances. It is mostly actually the new theory is that it is something related to developmental disorder in the testicular tissue itself, in the seminiferous tubule, tissue itself in that patient. All right, we did talk about this. All right, so where do you put it? Like I told you, it doesn't matter really. Some study, depending on the study you read, one will tell you 1, 2, 3. Some others will tell you put it down in 10 years. I say it does not really protect against anything. At the end of the day, the risk will always be there. Now, for a patient who is in this situation, what you need to do, you need to follow them through time. You need to, examine them periodically. You have to actually do physical exam, and you need to ascertain that, and you need to tell the patient if they have any sign, any symptom actually to come in, for a checkup right away. But there is also a schedule of testing. Now, if someone, presents to you with a mass in the testes, what do you do? If someone presents to you with a mass anywhere in the body, what comes to your mind?
Physical
Biopsy.
examination.
Check if it's malignant.
Right, how do you do that?
Biopsy.
Biopsy, right? Now, unfortunately, I hate to break it to you, you can't do that in the testis.
Why not?
You cannot do that in the testis, because if it's malignant, and there's a good chance that it may be malignant, of course you do a lot of tests, before you think about this is American medicine, you first start with non-invasive test, and then you go into invasive test. You start with a cheap test, and then you go into expensive test. So after you do all your tests that you can muster, let's say ultrasonography, CT scan, whatever it is really, then the gold standard is going to be what? The tissue, right? To look at the tissue. Now, when it comes to testicular masses, you cannot actually biopsy the patient because of the fear that it could be malignant, right? And the only way for you to rule out malignancy is if you take a piece of tissue and look under the microscope, correct? So in this case, what you need to do, you need to actually, you need to come in and you need, believe it or not, to take the testes in shell or orchiectomy. How about that? Does that sound extreme to you? That's pretty extreme, but this is unfortunately the way to do it. The reason for this is that if you probe, if you do, let's say, open biopsy, or let's say that you do fine needle aspiration like you do in other organs. When you take, so you go in, no problem. When you go out, this knife or this needle is going to leave track, right? Track of cells. And it is proven that those cells themselves may grow actually, resulting in implants. You have induced metastasis in this case. Metastasis where? In the scrotum. So the plastic surgery that you have to do in order to take out those implants and preserve whatever left of the contralateral testis is going to be impossible to perform. So you obviate the whole need for a biopsy, and you actually go into the OR, you take out that testis, and at the same time, because there is a chance that the contralateral testis may harbor a tumor, you have to probe the contralateral testis, but now you're probing it with an open scrotum. You see what I'm saying? And there is one nice slide at the end. Honestly, I did not believe it until I saw it, because it sounds incredibly radical, isn't it? Like the fact that you have to assume malignancy even before you have done, the treatment. But here it is, right there. You have a question?
No, you just answered.
Okay. All right. Good. Thanks. Yes, sir.
When they remove testicles, sometimes people have prosthetic testicles, right?
Prosthetic testing?
Yeah. Kind of like a glass eye.
I'm not sure about that. That's what they put. What kind of prosthetic?
I don't know.
I have never seen it before. I've never heard of it. Which is very unusual. I've seen a prosthetics for like during autopsy. You see that a lot. I've seen a prosthetics for it's not a prosthetic, a pump actually.
Yeah.
Like some people don't like to take medications for maintaining erection, and you would say, at one point in time, I was doing this other, but I've never seen a prosthetic of a testis. Maybe, I don't know. Go ahead.
Yeah, so you took one out and you saw
You
that.
probe the other one.
As well.
The scrotum is open right now, so
Yeah.
you're not going to be doing any seating, you're holding everything in your hand. So you take one out, you probe the other one. If the other one have IUCN, what do? You take that one out.
Okay.
Pretty extreme, isn't it?
Yeah.
But the first one you automatically remove it then.
Sorry?
For the first testes that has the mass.
No, you have to look at it, of course. So you take out the testes that have the solid mass. This is, again, remember I told you this already, so nobody can say. I told you that you go and do all the tests that you can do. You start with ultrasound, you just go CT. There is any, like MRI maybe, any special exotic, imaging, study that came out, you do that, okay? If there is any biomarker that you can use for all practical means, do it. But at the end of the day, you cannot probe that test. You have to do it, in one shell, and you have to cut it and look under the microscope. Further.
Do they usually metastasize fast?
You will see this not so bad really, especially seminoma, which is the most common. The majority of tumors in the testis is, most commonly going to be a seminoma, and seminoma have incredible, actually, I would say cure rate. One of my attending in the U.S., he's a Cuban American attending, probably the nicest one I met over there, unfortunately had a unilateral seminoma. And they took out one of the testes, and the guy actually had, because usually Cubans are very different than the rest of the population. Cubans are Catholics, and Catholics have a lot of kids. He had, I think, like 5 kids or 4 kids, so there was no problem. One testis will do the job, Excuse me, just 1 second. Hello. هلا سلامات دكتور، شو اخبارك؟ هلا. يا اهلين وسهلين، اهلين وسهلين دكتور. يا شو اسمه البي بي ال نعم. كان الفكرة انه بس يعني I know, no, I know, بس إذا نعم. أيوة. خلاص. طيب. يعني عنده شغل. نعم. نعم. تعال راسل. لا ما لها درجة. لا ما لها درجة أكيد أكيد don't worry about خلاص خلاص معناتها I will take her completely off anything else except your part. It's nice to have someone vouching for you, you know? It's not happen a lot. Okay, so question, I saw someone was talking, I think? What was you? Okay, hold on.
Yeah, you answered.
Okay, good. All right, so now let's talk about how does it look like actually? How does cryptorchidism look like? So cryptorchidism, you know, imagine this testis that has been out of place, you know, exposed, trauma, you know, ischemia, over the long run. You know, the ischemia did not really happen suddenly, otherwise the patient would come in, you know, like with a sudden, you know, stormy kind of clinical picture. It happened over a long period of time. Similar to what you see in other entities. So this patient with the cryptorchidism is going to have all the features in histological sections that you see with testicular atrophy. Okay? Meaning, you look at, this is the normal, always, you know, pathology is what you say, you know, normal versus abnormal. You look at the two and you are able actually to maneuver. So you look at these actually testes right here, and you see the seminiferous tubules that are very well circumscribed, right? A very thin basement membrane, correct? And even out, you know, there is, you know, open space, open, you know, what you call a stroma. You know, few Leydig cells in the stroma. You look at the lumen of the seminiferous tubule, and you will see that there is actually sperms. All these are sperms. So active spermatogenesis is happening, right? Now compare this picture to this picture of not just cryptorchidism, but any testicular atrophy. What you're going to be finding, you're going to find that actually that the seminiferous tubules are haphazardly arranged, right? A lot of disarray. You know, they are not evenly placed. That's number one. Number two, you look at the basement membrane, and the basement membrane is very thickened, correct? Two. You look at spermatogenesis, and none of them have spermatogenesis, so lack of spermatogenesis, there is no sperms in the lumen. All right. You look at the stroma, and the stroma has become hyalinized. And then you look at the stroma, and you will see that there is increased number of Leydig cells. So there is what you call, some people believe that there is Leydig cell hyperplasia. Others will tell them that actually because of the fact that you have, you know, that you have a hyalinized stroma, those Leydig cells that were there in the beginning are now going to be standing out. Either way, it looks like there is increased number of Leydig cells. So all of those features are what you see in any testicular atrophy. What causes testicular atrophy? We talked about profession, right? Someone who's actually standing in front of a pit of fire, you know, that may eventually, in the long run, result in destruction. How about ischemia? Could it do the same? Absolutely. How about cryptorchidism? Could it do testicular atrophy? Absolutely. Now, on top of this, with cryptorchidism, you're going to be having actually one additional component to it, which is the IGCN. So what's the IGCN? IGCN is simply carcinoma in situ. So if you look at these cells, these are highly dysplastic cells. How do I know that? Don't take my words for it. Look at, you know, the shapes of these nuclei.
Hyperactive.
It looks hyperchromatic, right? That's one. Two, they are pretty large, right? And they stay large all the way in. Is there any spermatogenesis? No. There is a mitosis right here. Here's another one. So mitotically active. And then, you know, how about the NC ratio? The NC ratio has increased a lot. Look at this. All right? NC ratio has, you know, is there too. So lack of maturation toward the surface, NC ratio, that is very high, you know, and then there is dysplastic looking nuclei, hyperchromatic nuclei, you know, and a lot of disarray, lack of spermatogenesis. All of those are actually signs of carcinoma in situ, if you guys recall, you know, what you have taken in the POD. Okay? So, you know, you're looking at actually a cancer that has not become invasive yet. How does it become invasive? When it breaches the basement membrane. Okay? When it goes through the basement membrane, then it can become actually what you call, you don't call it like carcinoma in situ anymore or IGCN. You're going to be calling it, you know, the name that the cell will take shape of. So you may be calling it seminoma, we will be calling it yolk sac tumor, and so on and so forth. So a couple of words about the IGCN. The IGCN is the forerunner of all clinically detected or apparent testicular neoplasm. This is ground zero for everything. So imagine the ability of those cells of the IGCN. Highly, what do you call it, pluripotent in terms of their ability to give rise actually to a clinically invading tumor. All right, so this is actually what we call a PLAP stain, placental alkaline phosphatase stain. For a long time, again, you will see in medicine and pathology, especially, there are two, schools. One school that will tell you the stain works, the other school will tell you the stain does not work. Robbins actually take the side of the fact that PLAP does stain, those IGCN cells, and it does in this case. Those cells have picked up the stain. It's a cytoplasmic stain, as you can see here. All the IGCN cells, all the dysplastic cells have taken up the stain. So if this is the same seminiferous tubule, the majority of the cells are actually malignant cells, if you will, right? So what's IGCN? IGCN is cancer, but it is still limited by the basement membrane. This is something how
What's the cell origin of IGCN? Which cell did they come from?
it's a germ cell. It is a germ cell, a dysplastic germ cell. That is the mother cell, if you will, of this clinically still localized tumor. All right, so this is something that we have just talked about. This here, right here, everything is here. Right, where do you see the IGCN? In 80% in the rest of the testes, in a testis that is affected with a germ cell malignancy, and in the contralateral testis in about 5% of the time. Sometimes incidental findings, you see it in the intersex states. You may see it also during workup of infertility, and you know now why those patients are going to be presenting with infertility. This is the cause of it right here, because the IGCN tubules are not going to be fertile. They are not actually undergoing spermatogenesis. They are simply malignant cells. So this explains why they will be presenting to the infertile clinic. So what are the testicular tumors? Testicular tumors in general. Wow, 3 minutes to go. Sorry guys, I'm sorry that I'm late, but we will finish it here now. So starting with the germ cell tumors, or do you want to do it online? I have no problem. We can take 10 minutes. I need only 10 minutes from you. How do you want to do that? Answer quickly.
Yes.
10 minutes online, right? Or so I can do it online anytime you want, today for example. Or I will ask the girls to actually record it. It's up to you.
Yes.
Or we can do it next week, the first 10 minutes.
Let the girls
Let the girls record.
Next week. If not, all right. I will see you next week. Take care.